let us enter into the whole new world of endocrinology. Endocrinology is a science that deals with hormones. We know that, but many students do perceive this endocrinology as one of the very tough topics. Actually, it's not supposed to be. It's one of the very beautiful and easiest things to understand and comprehend, provided if you know the nature and purpose of why these hormones are existing. At the same time, if you understand the basic feedback loops in a much better way. So as I told you before, endocrinology is a subject or a science that's going to deal with hormones. So what do you mean by a hormone? Hormone literally gets translated into something called to set in motion. So this is what you mean by a hormone in the first place. Alright, so you have three basic signaling mechanisms in the body. One is the endocrine signaling mechanism, and second one is the paracrine signaling mechanism, and the third one is the autocrine signaling mechanism. Alright, but even though the term hormone should be used only for substances that work by this endocrine principle, it's often utilized for both paracrine as well as autocrine. That's not a sin obviously, but sometimes they interchangeably use for paracrine as well as autocrine mechanisms also, because the same substance may have multiple routes of action, like endocrine also as well as paracrine also, which I'll tell you in some time. So that's the reason sometimes the hormone term will be extrapolated to paracrine and autocrine mechanisms also. But ideally speaking, the term hormone should be used only for substances that work by this endocrine principle. So what do you mean by endocrine principle in the first place? You can see this cell is secreting a substance here, some substance, and that is entering the blood. It's a very, very crucial component of endocrine system. They enters the blood. This entering the blood is the one that gives the understanding about endocrine, that gives the property of a particular name called endocrine system. So it enters the blood, that is the intravascular compartment. In the blood it travels to some distant area where they are going to exert their action in the distant target cell. So this is what we call it as a endocrine system, endocrine mechanism of action. And any substance that works by this endocrine principle is what is supposed to be called as a hormone. But even though I told you, they can be extrapolated to paracrine as well as autocrine mechanisms. What do you mean by paracrine? Paracrine means a substance that is synthesized and secreted by a particular cell is acting on the neighboring cell or a nearby cell, target cell, and they are not going to go via the blood, or they are not going to go for a distant site through the blood. Instead, they are going to act on the neighboring cell by a simple process called diffusion. So this is what we are going to call it as a paracrine mechanism. So what do you mean by an autocrine mechanism? Here, the cell synthesizes some substance obviously, and this substance is going to exert its effect on the same cell that is synthesizing and secreting it. So this is what we are going to call it as an autocrine mechanism. As I told you before, the same substance can work as an endocrine principle, endocrine substance, or they can work as a paracrine substance also. Ideally speaking, a substance that is working by paracrine autocrine mechanism should be called as factors only rather than hormones. But don't get confused, it's not a sin. I told you, you can interchangeably use the term hormone to paracrine as well as autocrine mechanisms also. Why? Because I told you the same substance may have multiple different effects and routes of action. For example, you have D cells in the stomach. Let us take D cells are present in many areas in the GIT, but let us take D cells in the stomach. They secrete a very important hormone called the somatostatin. So this somatostatin is going to inhibit G cells in the stomach. These G cells are going to secrete gastrin, which means the idea of releasing somatostatin is to suppress the gastrin release. Alright, and you can see very clearly this is a typical paracrine mechanism of action, as this D cells and G cells are neighboring cells present next to each other in the stomach. Right, they are not going to go by the blood route and they are going to inhibit each other. So this is something a typical paracrine route, but at the same time we know this somatostatin also is going to have distant actions, which means they can also inhibit hormones elsewhere, which means they can also inhibit the hormone secretion elsewhere in the body also, especially in the GIT. So we know that this is having endocrine action also. That is the reason why sometimes this paracrine, autocrine, endocrine, these substances generally we call it as hormones, but ideally speaking, again I'm telling you, a hormone means those substances that work by endocrine principle. Clear? Autocrine, it's important only in two areas. One is early embryogenesis, where during embryogenesis you have these cells has to proliferate very rapidly so that they secrete some factors which act on themselves so that the proliferation will be doubled or tripled. So this is a typical example where you get autocrine mechanism. And second is malignancy. Malignancy, again, the proliferation should be exponential and they grow very rapidly. So for that, they secrete a lot of growth factors which act on itself, and that's another example of how autocrine system works. Endocrine, you have a lot of examples because in this particular entire whole chapter, we are going to discuss on the endocrine principles only. Let us go to the next segment on classification of the hormones. How you are going to classify the hormones in the first place. So hormones can be classified based on two entities. One is they can be classified based on their chemical structure, and second one they can be classified based on the chemical characteristics. I would say this classification based on chemical characteristics is going to make a lot of sense compared to classification based on the chemical structure. But let us see both. So classification based on structure, they classify based on whether it's a steroid hormone or a amine based hormone or a peptide or a protein hormone. Clear? Peptide or a protein hormone. So based on the characteristics, you have two groups of hormones. Either it could be a lipophilic hormone, which is supposed to be a group 1 hormone, or it could be a hydrophilic hormone, which is supposed to be a group 2 hormone. Clear? Again, I told you this based on characteristics. Hormone classification based on characteristics is going to create a much more better sense. But let us see both. So how can we classify based on structure? We have steroid hormones, we have amine based hormones, and we have peptide or protein based hormones. Alright. So what is the derivation? Where they are derived from? Basically, the basic derivation of steroid hormones are going to be from the cholesterol. Alright, this is a no-brainer. Every single medical student will know this. Steroid hormones are obviously going to originate from the cholesterol. And amine-based hormones come from a single amino acid. Single amino acid forms the basis of all these amine-based hormones. And peptide and protein-based hormones, it's going to be multiple amino acids forming peptide chains, or a protein when more and more peptide chains are linked with each other and they form a characteristic protein molecule. Clear? So what are the examples? What are the examples? Examples of steroid hormones are the ones, those are derived from either adrenal cortex or from the gonads. So they can be coming from the adrenal cortex, or they can come from the gonads or from the fetoplacental unit as well. So what are the examples of hormones that come from the adrenal cortex? You have mineralocorticoids like aldosterone, you have glucocorticoids like cortisol, and you have adrenal androgens like dehydroepiandrosterone. You know that these are adrenal androgens. What are the hormones that come from the gonads? You have testosterone, you have estrogen, and you have progesterone. Or they can come from the fetoplacental. Majority of the hormones that come from the fetoplacental unit are steroid hormones only. So let us now go to the amine-based hormones. What are the amine-based hormones? It can be based on single amino acid like phenylalanine, tyrosine, tryptophan, or even histidine. So what are the hormones in this group? First one, there are a group of hormones which originate from phenylalanine. These are characteristic catecholamine hormones. What are the catecholamines? We have dopamine, we have noradrenaline, and we are going to have adrenaline finally in the pathway. So this whole synthesis mechanisms we'll discuss later, but let us move on to the other amine-based hormones. Next is the tyrosine-based hormones. We know the most important tyrosine-based hormones in the body is the thyroid hormone, T3 and T4. We know that pretty well. And next we have tryptophan-based hormone. The most important tryptophan-based hormones are going to end with tonins. The classic tonins, there are two types of tonins. One is the serotonin and next is the melatonin. Clear? So these are the two tryptophan-based hormones. And we have histidine based hormones. One characteristic histidine based hormone, obviously it has his in it, so we are going to call histamine. So these are the different amine based hormones. What are the peptide based hormones? Peptide based hormones are chains of amino acids, so it can be small neuropeptides or it can be larger peptides also. Small neuropeptides, there are 4 hormones that you have to know. The first one is the TRH, TSH releasing hormone, that is coming from the hypothalamus, isn't it? TRH. And this TRH is supposed to be the smallest peptide based hormone in the body. For example, it has only 3 amino acids, which means only 3 amino acids. You have to know the sequence. It has glutamine, histidine and proline. So only 3 amino acids. Second, we have oxytocin, and third we have vasopressin. Both oxytocin and vasopressin are going to have only 9 amino acids, very small. And number 4, finally, we have GnRH, that's gonadotropin releasing hormone. They are going to have only 10 amino acids, again very small. We have larger peptide hormones. These are very common, larger peptide hormones. We can tell only examples because there are a lot of many hormones under this group. Examples are prolactin, insulin, glucagon. All these things are peptide based hormones or protein based hormones only, you know that. So these are the basic classification regarding the structure of the hormones. And what are the chemical characteristics of these hormones? Character wise, this steroid hormones obviously tends to be lipophilic, there is no doubt about that. But whereas your amine based and protein or peptide based hormones tend to be hydrophilic. But a major exception for this rule is the thyroid hormone, because thyroid hormones tend to be lipophilic in nature. Clear? So all the amine and peptide based hormones are hydrophilic except thyroid hormones, which are lipophilic. Apart from that, any steroid hormone is lipophilic. Remember, vitamin D may be considered as a hormone or may not be considered as a hormone, and again that is dependent on which book you read and how you understand. I consider vitamin D as a hormone, but it depends all up to you. So, but vitamin D is also lipophilic agent only. So, we consider vitamin D as one of the important hormones only. But clear. So, these are the classification based on the structure. Now, let us classify based on the chemical characteristics of the hormone. I told you 2 groups of hormones. One is group 1 and group 2. Group 1 is going to be lipophilic and group 2 is going to be hydrophilic. Alright. And what are the examples of lipophilic and hydrophilic hormones? I told you any steroid hormone is going to be lipophilic only, and you have thyroid hormones. This is the only amine based hormone that tends to be lipophilic. And the third one, we have vitamin D, calcitriol. Obviously, if you consider this as a hormone, this also will come under lipophilic group only. And what are the group 2 hormones? They are hydrophilic hormones, which means all amine and peptide and protein based hormones tend to be hydrophilic only, with the only exception being thyroid hormones. Apart from this, every other single amine, peptide and protein based hormones tend to be hydrophilic in nature only. Because they are lipophilic, that gives some important character. That is the case that they tend to be crossing the cell membranes. They tend to cross the cell membranes. But remember, these hydrophilic hormones, because the cell membrane is made of a lipid bilayer, if they are not lipid soluble, they cannot cross the cell membrane. These hormones cannot cross the cell membrane. So how they are going to exert their effects? Obviously, you know that the receptors for these hormones tend to be typically intracellular. Obviously, yes, because they can cross the cell membrane. Very simple fact. But the receptors for this hydrophilic hormone group, that is group 2 hormones, tend to be cell surface only. They cannot go into the cell. So which means definitely there will be only cell surface receptors for this group 2. That is hydrophilic hormones. What is the activation principle? Let us draw two cells here. Activation principle is quite simple. The first activation principle, these hormones can enter the cell membrane and go into the cell, which means inside the cell they enter easily because they are lipophilic, and inside the cell they have a receptor for them. This is called intracellular receptor, and together they form a complex called hormone receptor complex. And this hormone receptor complex will act on the certain areas of the DNA so that they can exhibit the effects on the certain genes by either increasing or decreasing the transcription of a particular gene. So very, very simple. So which means they are going to have intracellular receptors, that's very, very important, and they form a hormone receptor complex which exhibits their effects on the DNA and the genes. Whereas these cell surface receptors are not like that. You have a receptor on the cell surface itself where the hormone should bind, and they should cause some downstream effects inside the cell with the chain of protein molecules, and this is what we refer to as signal transduction. And this signal transduction inside the cell will have a particular effect. Clear? So this is how they are going to work. So which means they don't have intracellular receptors. These hydrophilic hormones are going to work by cell surface receptor principle only. Clear? So this is very, very important to understand. And similarly, whether you will have transport proteins or not. Whether you have transport proteins or not, answer is definitely yes, because in the blood they cannot be dissolved unless until they have a protein to carry them, these lipophilic hormones. That is the reason why, examples, cortisol binds to cortisol binding globulin, thyroid hormones bind to thyroid binding globulin, and testosterone binds to sex hormone binding globulin, or they can even bind to albumin. So some protein has to carry this lipophilic hormones, otherwise their half-life will be very short and they cannot dissolve in the first place, isn't it? So it's not possible. But for hydrophilic hormones, typically you don't have any transport proteins. Tell a transport protein for insulin, you don't have it. Tell a transport protein for glucagon, they don't have it. So you don't have a significant transport protein for these compounds, right? Because they have transport proteins, the half-life of these substances tends to be a lot higher, which means they will be in the hours to days most of the time, because they are more stable in the circulation. And because they don't have transport proteins, the half-life tends to be very short, which means usually it will be in the range of minutes only, because they are quite unstable and they can be degraded by multiple proteolytic enzymes and other actions in the body. Next, how they are degraded. So they have to be inactivated by conjugation principle. So which means this is the most important crucial step for inactivation of any steroid hormones by conjugation, or any lipophilic hormone by conjugation, which means they will be done in the liver and that will be excreted in the bile. That's it, because they are fat soluble, they have to be excreted in the bile. Whereas this protein, peptide or amine based hormones, except thyroid hormone obviously, so these lipophilic hormones will be degraded by enzymatic and proteolytic degradation. This proteolytic degradation can happen in many places in the body. Typically it happens in the kidneys and the liver, proteolytic degradation. Whereas this enzymatic degradation many times happen in the blood itself. Best example for this enzymatic degradation is catecholamines, like adrenaline, noradrenaline, dopamine and all these things, where they are acted upon by two enzymes called monoamine oxidase and catecholomethyltransferase, COMT, where they will form a lot of intermediates and finally they form a compound called VMA. Everyone will be familiar about this compound. It's called a mandelic acid, which will be excreted in the urine. This is the best example of a enzymatic degradation, which means it's based on two enzymes, MAV1, catecholomethyltransferase, COMT. So this is how they are degraded in the first place. Clear? So these are the basic differences between a lipophilic group 1 and hydrophilic group 2 hormone. That's why I told you this is the one that makes a lot of sense, to be honest, in our real practice, right? So real understanding in the first place. Now, let us see how the signal is getting transduced, how the signal transduction happens. It's quite simple for lipophilic hormones. It works by intracellular receptors, and for your hydrophilic hormones, they work by cell surface receptors. That's how the signals are getting transduced. So that's why we are entering into the new segment called receptors. Receptors are basically two types. One is the intracellular receptors. The second one is the cell surface receptors. Clear? Intracellular receptors, again, you have two types. One, it could be a cytosolic intracellular receptor, and second is the nuclear intracellular receptor, which means the receptor is located in the nucleus itself. Obviously, both these receptors are finally going to move to the nucleus, or which means final action will be on the final effect on the nucleus only. Final effect will be on the DNA in the nucleus. So both these receptors, but how they translocate is something different. For example, let me draw an intracellular receptor. This is a nucleus, and you have DNA segments with them. Okay, let us understand first. You have a hormone, which is a lipophilic hormone, and it's going to enter the cell, and they form a hormone receptor complex. We know that. So once they bind, they form a hormone receptor complex. This is for hormones that are cytosolic receptors. And once they form this hormone receptor complex, this hormone receptor complex will translocate to the nucleus, where they have their own, responding areas in the DNA. These are called as hormone response element, HRE, where they bind. This hormone receptor complex will bind there, and they can affect the transcription of a particular gene, which means they affect the genetic expression of a particular gene. They can increase or even decrease the effect of particular genes, which means they can increase or decrease the translation of particular protein, thereby altering the genetic expression. Clear? So that's how they work. Typically, you have lipophilic hormone, which may not have any receptor in the cytosol. Instead, they might have receptor in the nucleus itself, which means they directly go into the nucleus and bind with the receptor, and they form hormone receptor complex there in the nucleus itself directly, which can again act on the particular domain of the DNA, and they can accelerate or even inhibit the transcription of a particular gene, and thereby altering the expression of a gene. Fine. So my question is, what are the hormones that act by intracellular cytosolic receptor, and what are the hormones that act by intracellular but nuclear receptors directly? Intracellular, intranuclear receptors. Intracellular cytosolic or cytoplasmic receptors you get with steroid hormones. Typically, steroid hormones are the ones that have intracellular cytosolic receptors. Intracellular nuclear receptors, on the other hand, you get it for thyroid hormones, or you can get it for vitamin D receptor. Vitamin D receptor is also intracellular and intranuclear only. Now let us see some of the cell surface receptors. So cell surface receptors are of three types basically. One is the standard G protein coupled receptors called as GPCRs. If somebody asks you what is the most common or the most abundant receptor types in the body, you have to answer it as a G protein coupled receptor. Almost 70% of all the ligands, they may be factors or some hormones, they act through this G protein coupled receptors only. Second, we have enzyme linked receptors. A lot of examples of enzyme linked receptors are there. For example, you have receptor tyrosine kinase called as RTKs, then you have non-receptor tyrosine kinases called as NRTKs, and you have receptor serine threonine kinases called as RSTKs. And finally, you have this ligand gated ion channel receptors. The best example will be nicotinic muscle type receptor, that's neuromuscular junction type receptor called NM type of receptors. Muscarinic and nicotinic both are acetylcholine receptors. So in this NM type, you know that whenever acetylcholine binds in the neuromuscular junction with the NM type of receptor, they act as ion channels. Once the acetylcholine binds, they open up and they cause influx of sodium, which causes depolarization in the muscle and causes muscle contraction. Example. So in this particular video, we're not going to discuss on the ligand gated channels. We'll be discussing only on the enzyme link receptors and the G protein coupled receptors. So understanding about these receptors is really important because it gives you a potential understanding for therapeutic targets also, because a lot of catecholamines are going to act through GPCR only. So targeting these GPCRs sometimes may be useful in the treatment also. For example, you give beta blockers, you give alpha blockers, you are giving beta 2 agonists, you are giving alpha agonists. All these things are going to work through this subtypes of this G protein coupled receptors only. Fine. Similarly, your receptor tyrosine kinases, you know very well, lot of growth factors act through receptor tyrosine kinase only. That's why this RTK pathway is also called as a growth factor pathway. So VEGF, PDGF, epidermal growth factor, EGF, then FGF, fibroblast growth factor, all these growth factors are going to act through this RTK pathway only, which means targeting this RTK pathway may be a potential treatment for cancers because they are mitogenic, growth promoting pathways. So they are oncogenic pathways as well. You have a lot of oncogenic proteins that act as subsequent signal transducing agents in the receptor tyrosine kinase pathway, which we will discuss. The most important is the RAS MAP kinase pathway and PI3K-AKT pathway. Both are very, very important oncogenic pathways. That's why targeting these pathways may be useful in treating the cancer. And next, you have NRTKs, non-receptor tyrosine kinases. And differences between RTK and NRTK I will tell you here itself, because again we are going to discuss anyways. Difference between RTK and NRTK is very simple. These receptor tyrosine kinases have their intrinsic tyrosine kinase activity in the receptor itself. They are not dependent on either protein. But your non-receptor tyrosine kinases, that is NRTKs, they don't have their intrinsic tyrosine kinase property. Instead, they have the tyrosine kinase property, but they will depend on the tyrosine kinase ability. That's the kinase ability from an external protein called a JAK protein, which will be attached with the receptor. This is not the part of the receptor itself. This is an external protein. This is a JAK protein that is attached with the receptor. The tyrosine kinase is actually coming from the particular JAK receptor. So that's the one difference between a receptor tyrosine kinase and a non-receptor tyrosine kinases. That's why this pathway is also called as JAK pathway, or we call it as a famous JAK-STAT pathway. Why this pathway is important? Because this is a pathway for the cytokines. A lot of cytokines are generally going to act through this pathway only. That's why targeting this pathway may be useful in the treatment of autoimmune disorders. Targeting this pathway may be useful in autoimmune disorders plus few myeloproliferative neoplasms. In those areas also this pathway targeting will be very useful, especially for autoimmune disorders like rheumatoid arthritis, psoriasis, and a lot of conditions where they typically target the JAK proteins. We call these compounds as JAK inhibitors, which we will discuss in the same video. Fine. So that's why the elegant understanding of all these pathways are really important to understand the treatment aspects of different diseases. Now we will go to the ever important G protein coupled receptor. We know G protein coupled receptor is a membrane spanning receptor. This is a lipid bilayer. That's why I put 2 lines. It has 7 transmembrane binding domains. You have extracellular site and you have intracellular site. 7 transmembrane binding domains, and all these domains are made of alpha helices. And usually the ligand binds to the area in between the 2 alpha helices or in between 2 domains, and on the internal side, on the inside of the cell, you have a protein that is attached to called a G protein to the receptor. And this G protein has 3 subunits, alpha, beta and gamma subunit, and that's why this G protein is also referred to as a heterodimeric protein, which means it has 3 different proteins, that is alpha, beta and gamma. In that the alpha will always be bound to GDP or GTP. If it is bound to GDP, which means it's in the inactive state. If it's bound to GTP, means it's in the active state. So which means the alpha unit or alpha subunit of this G protein will be either bound to GDP or GTP. Bound to GDP means it's inactive. If it's bound to GTP means it's active. So if I tell more than this, you will be confused. Let us see in the form of a diagram. This is an example of a simple GPCR loop where this is the G protein coupled receptor. You can see 7 transmembrane binding domains are there, and where in between the domains your ligand is binding. Once the ligand is bound, the G protein, so this is the G protein, let me show you. This is the G protein. G protein, I told you, has 3 subunits, that is alpha, beta and gamma. In that the alpha is usually bound to the GTP or the GTP. Why I have shown GTP here is because there is a ligand that is stimulating the receptor so that the G protein will be activated. Once G protein is activated, they will be bound to the GTP only. So what's going to happen is they are going to dissociate into beta and gamma subunit separately and alpha subunit separately along with the GTP. This is called an alpha GTP unit. This alpha GTP then binds to a substrate. The substrate can be anything, but usually depending on the type of the G protein coupled receptor, you have three types: GQ, GI and GS. But depending on the type, it could be either a adenylate cyclase or it could be a phospholipase C, PLC. It could be either an adenylate cyclase or it could be a phospholipase C. These are the standard substrates. For example, for GQ and for GS and GI type, adenylate cyclase is the substrate, whereas for GQ type of receptors, phospholipase C is the substrate. So GS means they activate the adenylate cyclase, whereas GI means they are going to inactivate the adenylate cyclase. Similarly, GQ always has activating effect on phospholipase C. So obviously, let us see that later on. So these are the substrates for this alpha GTP complex. Once activation of substrate is over, they go for spontaneous hydrolysis, which means this alpha subunit itself has something called intrinsic GTPase activity. This alpha subunit itself has intrinsic GTPase activity. This GTPase is going to hydrolyze GTP into GDP. Once they form GDP, they will become inactive now. And now they combine with that beta and gamma, which has already been separated, and they form a full alpha beta gamma GDP complex, which is nothing but it's a full inactive G protein. Once again, it will be translocated to the inside of the cell, finding attached to the G protein coupled receptor. That receptor will be attached with the G protein. So this is how the cycle goes, and this is how the principle works. And as long as the ligand is binded, as long as the ligand is bound to the receptor, this G protein will always be in the activated state, which means this, the alpha GTP will always be separated from the beta and gamma. But sometimes it might result in uncontrolled regulation, uncontrolled activation of this GPCR pathway. So that is why we have a check how to prevent this uncontrolled activation. Suppose if a ligand is binding continuously and it's stimulating the GPCR continuously, means there is a protein or there is an enzyme called GRK. It's a kinase actually. GRK that's going to phosphorylate the transmembrane receptor. Suppose if the ligand is bound continuously to the receptor, then they will phosphorylate. This will be identified by an enzyme called GRK, a kinase called GRK, which is going to phosphorylate this transmembrane domain. Clear? So once this the transmembrane receptor is phosphorylated, that will be identified by another protein called as arrestin. That will be identified by another protein called arrestin. This receptor, this protein, the arrestin protein, will block the communication of the receptor with the G protein. So which means they detach the G protein that is inactive and they will detach it from the receptor, and both cannot be bound now. So if both cannot be bound, the entire downstream signaling will be affected and they cannot form any more signaling. So this happens whenever there is a continuous stimulation from a particular ligand on the G protein coupled receptor. So two things you have to know. One is the GRK is a kinase that phosphorylates the G protein. Second is the arrestin. Arrestin is going to separate or detach and prevent the communication of G protein with the receptor. It's a respective receptor. So which means there will be no coupling and there will be no activation of the downstream pathway. So this is how, these are two important things that you have to understand. And once the G protein and the receptors are separated by arrestin, so this transmembrane receptor now without this G protein will be, it's like a useless protein, so they will be endocytosed by clathrin coated pits and they will be degraded in the lysosomes, which means they will reduce the number of G protein coupled receptors on the surface of the cell. The idea is simple. What I am trying to tell is the tachyphylaxis. So you know what you mean by tachyphylaxis, where continuous stimulation of the ligand on its receptor may result in the down regulation of the receptor. That's what we call it as tachyphylaxis. So that's what happens here. They will down regulate the number of receptors that are found on the surface for the ligand to act again and again. So this is the basic principle. So now I think you have understood the G protein coupled receptor pathway. After understanding this G protein coupled receptor pathway, let us see the common receptors that will be asked in exam which acts through the G protein coupled receptor pathway. We have three types of GPCRs. We know that is called GQ type, then is GS type and GI type. A lot of receptors act through this GQ, GS and GI. For example, your alpha receptors, your beta receptors are there, then parasympathetic receptors, or we can call it as muscarinic receptors, and histaminic receptors, or histamine act through this GPCRs only, and dopamine also act through GPCR only, and vasopressin also act through GPCR. Some examples, that is very important exams. So what are the alpha receptors that are of GQ type or GS type or GI type? One alpha receptors of GQ type, that is alpha 1 receptor, very important point. And alpha 2 receptors are of GI type, which means there is no GS type of alpha receptor, sympathetic alpha receptors. Clear? We are talking about sympathetic system, which means this alpha and beta are going to come under the sympathetic system. GQ alpha 1, GI it is alpha 2. So there is no GS type of alpha receptors. But whereas beta receptors, you have beta 1, beta 2, beta 3, all these three things will come under G stimulated type only, and they don't have GQ or GE type of receptors under the beta section. And muscarinic receptors, M1 and M3 receptors are typically GQ type, and M3 receptors are typically GI type, and GS type again you don't have any much muscarinic receptors. Histamine, H1 receptors and H2 receptors. H1 is GQ type and H2 is GS type, but you don't have any GI type. What about dopamine? Dopamine acts through D1 and D2 receptors, whereas D1 is a G stimulated type, D2 is a D inhibited type, and you don't have any GQ type of receptors with histamine. So what about the vasopressin? Vasopressin V1 receptors act through GQ type and V2 receptor act through GS type, and there is no actually GI type of receptor. So this is what is very, very important to understand. So these are the different types of G protein coupled receptors that you have to know which ligand acts on what. What could be the substrates? Substrates we discussed already. For G protein GQ type of receptor, it is phospholipase C only. There is no doubt about that, where it's going to stimulate the phospholipase C, whereas this that alpha GTP complex, that's what you're talking about. Then we have GS and GI type of receptors, and GS type of receptors, it is the adenylate cyclase that's going to be the substrate, where it's going to stimulate the adenylate cyclase, whereas in GI type again adenylate cyclase will be the substrate where they're going to inhibit the adenylate cyclase. So I told you, once the substrates are activated, once this something happens to the substrate, they are going to act on other proteins, and these proteins are often referred to as second messengers. Clear? They are going to act on other proteins inside the cell, and these proteins are often referred to as second messengers, which means what are the second messengers that are activated or inhibited by this particular pathway. So GQ, the important second messengers are inositol triphosphate and diacylglycerol, where because you are increasing the phospholipase activity, your IPG and DAG also will increase. Similarly, for adenylate cyclase, the most important substrate is cyclic AMP. Clear? You know very well, since GS activates the adenylate cyclase and increase the activity of adenylate cyclase, your cyclic AMP levels are going to increase. Similarly, since GI type reduces the adenylate cyclase activity, they reduce the cyclic AMP levels. Clear? So these are some of the important aspects that you have to know. And apart from that, what increased cyclic AMP or what decreased cyclic AMP and what increased IP3 and DAG is going to contribute to, because they have the effector molecules. Final effector molecules. What are the final effector molecules? The phospholipase C pathway that activates the IP3 and DAG is going to increase the protein kinase C. And similarly, this G stimulated type, which increases the cyclic AMP as second messenger, is going to increase the protein kinase A activity. And similarly, this GI type is going to reduce the protein kinase A activity. Clear? So GS will increase protein kinase A. Similarly, GI will reduce the protein kinase A. So these are the final effector molecules that you have to know. Fine, all right. So the CMP degradation is also very important. The CMP can be degraded by a group of enzymes called phosphodiesterase, because we have phosphodiesterase inhibitors also in the market, which is again very important to understand. Clear? So let us assume a classic example of a G protein coupled receptor. This is given in every single pharmacology textbook. You know that this is a cell. Let us assume this is a cardiac cell or a myocardial cell. Cardiac cell or a cardiac myocyte or a myocardial cell. You know, the most important G protein coupled receptor is the beta 1 receptor. It's a sympathetic receptor. Let us assume it's bound with a ligand called a noradrenaline, which is a natural ligand. Once noradrenaline binds, it's going to stimulate the B1 receptor. Stimulation of the B1 receptors, we saw already. B1 is a G stimulatory type, for example, which means they are going to cause activation of the adenylate cyclase and they're going to increase the cyclic AMP levels. So which means they're going to activate the adenylate cyclase. This activation of adenylate cyclase will definitely increase the cyclic AMP levels inside the cell. This cyclic AMP will increase the protein kinase A for sure. That's what we have been discussing. Clear? So phospholipase C, IP3DAG protein kinase C, whereas the cyclic AMP mediated, that is GS or GQ type, it is adenylate cyclase mediated. Usually action will be on the protein kinase A. So we know this is a kinase, protein kinase A. So what this kinase is going to do? This kinase is going to phosphorylate certain channels. These are called as L-type calcium channels. They're going to phosphorylate this channel. This phosphorylation of these channels means activation of these channels and more calcium influx into the cell, causing improved contraction of the cardiac myocyte. Clear? That's how this pathway is going to increase. I mean, they're going to have inotropic action on the heart or probably the chronotropic action of the heart. So this is how this pathway works by increasing the intracellular calcium. Similarly, you can utilize this pathway in many ways. I told you the cyclic AMP can be degraded by phosphodiesterase enzymes. In this particular example, we have a phosphodiesterase 3 in the myocyte that is very important, called phosphodiesterase 3. That is a typical phosphodiesterase enzyme in the cardiac myocyte. So let us see how this pathway is beautifully employed in a lot of treatment aspects. First, you have noradrenaline. You can simulate some substance similar to that of noradrenaline. For example, a dobutamine. Dobutamine, remember, it's a synthetic amine. Clear? It's not a naturally existing, it's a man-made one. Dobutamine is going to act on the beta 1 receptor with or without beta 2 receptor, that I will discuss later on. But primary action is on the beta 1. So that they can increase the force of contraction, inotropic potential of the heart. Similarly, you can increase the levels of cyclic AMP by blocking the phosphodiesterase enzymes. Phosphodiesterase 3 inhibitors are classically amrinone and milrinone, which can be typically used as inotropic agents. Obviously, it's one of the heart failure medications, isn't it? So, very good example. Similarly, many other phosphodiesterase inhibitors like sildenafil, tadalafil, they are phosphodiesterase 5 inhibitors, predominantly in the vessels. And you have phosphodiesterase 4 inhibitors like roflumilast, silomilast. These are phosphodiesterase 4 inhibitors, typically present in the bronchus, phosphodiesterase 4 enzyme in the lungs, where they are helpful in bronchodilation. And you have non-selective phosphodiesterase inhibitors like theophylline also. Similarly, you have a phosphodiesterase inhibitor called PDE4 inhibitor called apremilast, which is used in psoriasis, which we'll discuss later on in rheumatology. Similarly, a lot of phosphodiesterase inhibitors are there, so that can enhance the levels of cyclic AMP inside the cell. Because of that, they have so much of effects inside the cell. Okay. Similarly, you can actually reduce the inotropic potential of the heart by giving beta blockers or calcium channel blockers. For example, if you give a calcium channel blocker, it's going to reduce the intracellular calcium and they're going to have a negative inotropic potential. Similarly, if you give a beta blocker, typically beta 1 blocker means it's a cardioselective blocker. You are trying actually to reduce the intracellular calcium, and again beta blockers are considered as a negative inotropic agents, and that's why they are working as a negative inotropic agents. At the same time, if you want to increase intracellular calcium by any means, if you increase the intracellular calcium, definitely the force of contraction will improve. And what is the drug that increases intracellular calcium? In the heart, digitalis. How digitalis or digoxin works? Obviously, there is a protein and there is a molecule called sodium potassium ATPase, and this is something like a workaholic. It works 24/7. It pushes sodium to the outside and potassium to the inside in the ratio of 3:2. Clear? 3:2 is the coupling ratio of sodium potassium ATPase. So digoxin typically blocks the sodium potassium ATPase in the cardiac myocyte. Because of this fact, you can see the sodium levels increase inside the cell. A lot of sodium are there inside the cell. This excessive sodium inside the cell is going to cause depolarization of the calcium channels that will result in release of large amounts of calcium into the cell, and this is the reason for positive inotropic potential of digitalis. So you can see how you can modulate at a ligand level, how you can modulate at the receptor level, or how you can modulate at the second messenger level by modulating the phosphodiesterase, how you can modulate at the third messenger level, that is at the calcium level also. So calcium is often referred to as the third messenger. You have to know that, because majority of the G protein coupled receptors and the GQ, GS and GI, the final culminating event will be the increase or decrease in the intracellular calcium. So that's the reason why calcium is also referred to as the third messenger in this particular pathway. So very, very important. So this is some example how can tell you can modulate at the ligand, then you can modulate at the receptor level, you can modulate at the second messenger level also, you can modulate at the third messenger level also. Everywhere you have drugs. So all these things you have to understand. Alright. So this is a very simple G protein coupled receptor pathway principle. So once we have finished this G protein coupled receptor pathway, let us move on to the enzyme link receptors. Among the enzyme link receptors, only two receptors are important, that is receptor tyrosine kinase and receptor non-receptor tyrosine kinases, NRTKs. Let us see first the receptor tyrosine kinases. If you see the diagram, you will understand much better. This is a receptor tyrosine kinase. What are the receptor tyrosine kinases? You can see the receptor itself has its own tyrosine kinase activity. This orange color that is shown, these are the natural intrinsic tyrosine kinase activity of the receptor. Whenever a ligand is binding with this receptor, they will result in dimerization of this receptor, clear dimerization of this receptor with intact or with activation of the tyrosine kinase activity. So once the ligand binds, the tyrosine kinase activity will be enhanced and activated. So they are going to cause autophosphorylation. They are going to cause autophosphorylation. Once autophosphorylation happens, they are going to phosphorylate other substances. Other compounds also will be other compounds. These are called substrates. Substrates, these also will be phosphorylated. Once they are phosphorylated, they will become more active and they will activate the downstream signaling pathway. You have a lot of downstream signaling pathway in this particular receptor tyrosine kinase pathway. For example, let us assume what are the effector and metabolic pathways that are associated with this receptor tyrosine kinase. It's very, very important, crucial to understand. Let us assume you are stimulating a receptor tyrosine kinase. By stimulating this receptor tyrosine kinase, I told you with a ligand, you will be activating a lot of effector molecules. There are two types of effector molecules that come under this receptor tyrosine kinase. First pathway we called as RAS MAP kinase pathway, and the second pathway we called as classic PI3K AKT pathway. Both are highly oncogenic, both are highly growth promoting pathways. Let us see what's going to happen. So when you activate this receptor with the ligand, so first there are a lot of variety of proteins will be activated in this side. For example, you have SHC, then SOS, then you have GRB2. These are the three important proteins that you have to know. These are the substrate proteins that will be activated. This is a cascade. So initially SHC, then you will have GRB2, then you will have SOS, like a cascade they will be activated. So once this cascade is activated, they are going to activate a protein called RAS. They're going to activate a protein called RAS. RAS is a very, very important protein because you have three types of RAS. I'll tell you why this protein is important. You have KRAS, you have HRAS, and you have NRAS. Why this RAS is important? For the one simple reason that this is the most common proto-oncogene that is mutated. Proto-oncogene that is mutated in a cancer. It's the most common proto-oncogene mutated in a cancer. If they ask you, that answer is RAS. Clear. Most common proto-oncogene mutated in lung cancer, RAS. Most common proto-oncogene mutated in pancreatic cancer, RAS. Most common proto-oncogene mutated in any human cancer type is RAS. And the most common subtype of RAS that will be mutated in a cancer will be KRAS. Among the RAS, this will be the most common subtype of RAS that will be mutated. And least common subtype of RAS that will be mutated is the HRAS. HRAS will be the least common that will be mutated. Fine, alright. So anyway, some RAS is there and RAS is getting activated. And once RAS is getting activated, it's going to bind with the GTP molecule. This forms a RAS GTP complex. And this RAS GTP complex, it's an active complex that's going to activate further downstream proteins. What are the proteins they're going to activate? They are called as MAP kinases. They refer to as MAP kinases. The first in the step is the RAF. RAF is a family of proteins that will be activated by RAS. So there are a lot of types of RAF are there. You have ARAF, then you have BRAF, then you have CRAF. In this, the most commonly mutated protein in cancers is the BRAF. BRAF is the most commonly mutated protein, oncogenic protein. Especially you have a mutation called BRAF V600E mutation. This is one of the very signature mutations of a lot of types of cancers. Like it can be seen in melanoma. Melanoma is one of the very, very important mutations. The most important cancer that harbors this BRAF V600E mutation is the melanoma. That's the first thing that comes to your mind. So next, it can be mutated in Langerhans cell histiocytosis, then Erdheim-Chester disease, which you have seen in hematology. Then it can be mutated in many lung cancers. It can be mutated in many colon cancers also. So a lot of cancers may show this mutation, BRAF mutation. It's the most common mutated gene among the RAF family of molecules. So this RAF family of molecules, we tend to call it as MAP3 kinase. One of the examples of MAP3 kinases are this RAF family of proteins, otherwise referred to as MAP-KK, kinase, or you can tell MAP3 kinase. So this RAF, once it's activated, it's going to activate further downstream pathways. For example, in this condition, they are going to activate a group of proteins called MEK. These are called MEK1 and 2, and these MEKs are also referred to as MAP2 kinases, or you can write as MAP-KK or MAP kinase. So you can write like that. So these are called as MEK. This MEK is further going to activate the downstream protein. These are called as ERK proteins. These ERK proteins are otherwise referred to as MAP kinase or MAP-K. Clear? Or MAP1K proteins. This ERK is going to go into the nucleus. Obviously, this ERK can enter the nucleus. Once they enter the nucleus, they can activate a variety of transcription factors. Lot of transcription factors. These are all growth promoting transcription factors. Like you have CFOS, CGen, then you have CMYC, clear, then ELK, ETC. So many transcription factors are there that can be activated inside the nucleus. So once these transcription factors are activated, they are going to bind to the DNA and they are going to increase the growth promoting proteins. Like they can secrete anti-apoptotic proteins. So somehow the growth will be stimulated for sure. So these are the transcription factors. So if they ask you what are all this, these are the transcription factors. In this, the gen only is important in one historical way because this is the first oncogenic transcription factor ever discovered. That is what we call CGen, the gen. Then most important is the CMYC. You would have studied in a lot of your hematological cancers. I'm not going to discuss right now, but you have to know that CMYC is a very important oncogenic transcription factor as well, which is very important in many hematological cancers like non-Hodgkin lymphoma. Fine. You have ERK1 and 2. Now you know what are MAP kinase family of proteins. You have initially RAF, then you have MEK, then you have ERK also. So these are the MAP kinase family of proteins. That's why this pathway is also called as RAS and MAP kinase pathway, which is a highly growth promoting pathway, and that's why any mutations in these regions will result in a tumor promoting effect, or they will result in a tumor or a cancer. Alright, now you have a lot of BRAF inhibitors and you have a lot of MEK inhibitors also. For example, what are the BRAF inhibitors you have? What are the agents that you can use as BRAF inhibitors? The characteristic agents are dabrafenib, and you have vemurafenib, you have dabrafenib, you have vemurafenib, and you have encorafenib. Yeah, encorafenib also. Clear? So these are the three characteristic BRAF inhibitors. In this, vemurafenib is very commonly used, and all these are approved for melanoma. Very important cancer, I told you. BRAF is equal to melanoma. And similarly, you have MEK inhibitors also. For example, you can block the MEK also. These are called as mekinibs. They are BRAF inhibs. These are mekinibs. What are the mekinibs? You have trametinib, then you have cobimetinib, then you have binimetinib. So these are the classic mekinibs, and since RAF is going to activate MEK, mekinibs also used for melanomas only. So what are the combinations you can use? Dabrafenib with trametinib, vemurafenib with cobimetinib, and encorafenib with binimetinib. So these are the combinations they use for advanced stages of melanoma, not for initial stage. Refractory melanomas, you can use these combinations. These mekinibs and brafenibs, you have to know, because these are these are the drugs that inhibit the RAS MAP kinase pathway, receptor tyrosine kinase pathway. Clear? Since they are inhibiting the receptor tyrosine kinase pathways, these are called as NIBs. NIB means tyrosine kinase inhibitors, right? So these are brafenibs and mekinibs, which are currently approved in the market for various reasons, but the most important cancer that can be treated with these compounds is melanoma, malignant melanoma. Fine, alright. Similarly, you have this PI3K and AKT pathway also. What do you mean by this PI3K AKT pathway? I can write here. This PI3K means initially this activation, like how I have activated this SHC, SOS and GRB2 protein. Similarly, here I can activate the PI3K molecule. This PI3K molecule will help in the conversion of PIP2 to PIP3. That's called phosphatidyl inositol triphosphate. This PIP2 to PIP3 conversion is very important because this PIP3, phosphatidyl inositol triphosphate, is going to activate a molecule called PDK. They're going to activate this, a kinase, which is further going to activate another molecule called AKT, and this AKT is going to activate downstream another protein called mTOR. This mTOR is the one that is going to activate the cell cycle, and they're going to promote growth again. So that is why this is also referred to as PI3K AKT pathway, or you can write as PI3K AKT mTOR pathway. Clear? So we have discussed about this PI3K inhibitors. Already we have discussed about this PI3K inhibitor, which is one of the characteristic example in hematology I have discussed. This is called idelalisib. We have discussed that already, which is useful for treating many cancers. Like B-cell malignancies, your idelalisib is very useful, isn't it? BTK inhibitor, ibrutinib, we have discussed, and PI3K inhibitors, idelalisib also we have discussed. Clear? Especially for many conditions like CLL and all. We have used on non-Hodgkin lymphomas. We are using this idelalisib. Go to hematology section and see the videos again. So you have a lot of mTOR inhibitors also. This also we have discussed in hematology section. What are the mTOR inhibitors? We have sirolimus and everolimus. So these are the typical mTOR inhibitors, isn't it? Sirolimus and everolimus. So again, they can arrest the cell cycle and they can reduce the proliferation of the cells, and that's why they are used in cancers, and sometimes even in immunosuppression you can use the sirolimus and everolimus. Alright. So that's why the importance of understanding these pathways. So this is a very important tumorogenic pathway. So which means whenever you call a receptor tyrosine kinase means growth factors. What are the growth factors? Epidermal growth factor, fibroblast growth factor, vascular endothelial derived growth factor. Then you have epidermal we told already. So you have PDGF, platelet derived growth factor. So these are some of the growth factors that act which means the receptors that are responding to these growth factors will be called as just EGF receptors, which means the receptor tyrosine kinases that are responding to this growth factor are, those form the receptors for this growth factors are called as EGFR, that's epidermal growth factor receptor, or FGFR, fibroblast growth factor receptor, then you have vascular endothelial growth factor receptor, then you have PDGF receptor. Clear? Which means these growth factor receptors itself can be blocked, isn't it? These growth factor receptors itself can be blocked. Lot of growth factor receptor inhibitors are there. For example, these are also tyrosine kinase inhibitors. These are actually tyrosine kinase inhibitors, which will be called as NIBs again. One of the examples is imatinib. Remember, imatinib, you would have thought it's effective for inhibiting another fusion kinase called a BCR-ABL kinase. Remember, this is also tyrosine kinase only, but this is like a fused kinase. A BCR protein is there, ABL protein is there. Both have been fused, and they produce this a new fusion kinase called a BCR-ABL kinase, which has an excessive tyrosine kinase activity. Alright, go and see the CML video. You will understand what you mean by BCR-ABL fusion kinase and how the CML is generated from this BCR-ABL kinase. So this is a BCR-ABL kinase, and not only for BCR-ABL kinase, it can be effective for a lot of other kinases, especially PDGF receptor mutations also. Imatinib is very effective. I would have told you in hematology again. A lot of PDGFR mutations also do respond to. They are also receptor tyrosine kinase only. They also respond to this imatinib much better. Apart from that, you have a lot of other receptor tyrosine kinase inhibitors, RTK inhibitors like pazopanib, and you have fostamatinib, isn't it? Fostamatinib. If you recap where I have used fostamatinib is a splenic tyrosine kinase inhibitor, SYK inhibitor. So this splenic tyrosine kinase is very important for macrophages in the spleen, the reticular endothelial system in the spleen, to engulf this platelets and destroy them. That's why result in a chronic immune thrombocytopenic purpura. So this is a drug that is approved in a chronic ITP. Apart from that, a lot of other drugs are there. Sunitinib, then you have sorafenib, then you have nintedanib or nintedanib. Clear? So you have a lot of other tyrosine kinase inhibitors or receptor tyrosine kinase inhibitors. Remember, these tyrosine kinase inhibitors don't only have activity against one particular specific kinase, they have activity against multiple tyrosine kinase, receptor tyrosine kinase. For example, they will be effective for FGFR, they will be effective for VEGFR, they will be effective for PDGFR tyrosine kinase. So which means multiple receptor tyrosine kinases they can be effective for. That's why they are also called as multi-kinase inhibitors or multiple tyrosine kinase inhibitors. They will not be effective only for a particular single tyrosine kinase. They can be blocking multiple receptor tyrosine kinase. That's why they are also called as multi-tyrosine kinase inhibitors or multi-kinase inhibitors. Similarly, you can block the growth factors itself, isn't it? Typical example is VEGF inhibitor. What do you mean by VEGF inhibitor? You have bevacizumab, characteristic example, isn't it? You can directly block the VEGF itself. Clear? So that's called bevacizumab. We have a lot of other compounds like this. Similarly, ranibizumab, bevacizumab, ranibizumab. Now ranibizumab is being used in India. Bevacizumab and ranibizumab are approved for useful in diabetic retinopathy also. Many other proliferative diabetic retinopathy especially. So a lot of areas you can use, a lot of applications, other many cancers also you can use, even colorectal cancers now application is coming up. So a lot of cancers also you can use this growth factor inhibitors. So these are some of the examples. You will study EGFR blockers, FGFR blockers, PDGFR blockers specifically in specific cancers. So just understand all these are nothing but receptor tyrosine kinases, and these are receptor tyrosine kinase inhibitors. That's it. I think you get it. So that is how this entire pathway is important for understanding the tyrosine kinases only. Clear? So this is a typical example of how insulin works, because I told you what are the substrates for this. Anything that is a growth factor, it ends with GF, it's going to act through receptor tyrosine kinases only, right? Plus you have to remember insulin. Insulin is a very important growth factor, and even if I tell IGF, that is also going to act through this receptor tyrosine kinase only, because it's also growth factor. Insulin is a very important growth factor that you have to remember, that acts through receptor tyrosine kinases. Clear? So how this insulin is going to act. You can see once insulin binds, it's going to work through a pathway called IRS pathway. This is called insulin receptor substrate. How you had this SOS protein, GRB2, all these are substrates for this other receptor tyrosine kinase. Similarly here, you have this insulin receptor substrate, IRS, which is a substrate for this insulin receptor. This is a receptor tyrosine kinase. Once this insulin receptor substrate is phosphorylated, which means it's activated, they're going to activate two pathways. One is the RAS MAP kinase pathway. That's what we call MAP ERK pathway. Simply you can write as this is nothing but the RAS MAP kinase pathway, and they're going to increase the growth and they're going to produce more and more gene expression, especially of the proteins that are going to promote the growth. Number one. Then they can stimulate another pathway called PKB pathway. This is called a protein kinase B pathway. This is again very important because what you saw in the G protein coupled receptor, the effector molecules are actually protein kinase A and protein kinase C. Clear? For phospholipase C, you saw protein kinase C, and for adenylate cyclase and cyclic AMP pathway, you saw protein kinase A being either upregulated or downregulated. Some time back only we saw. But here, it is protein kinase B. That's what you have to understand. So protein kinase B is the one that's going to have multiple metabolic effects of insulin, like hypoglycemic effect of insulin and this lipolytic effect of insulin. So that RAS MAP kinase pathway, which is again a characteristic feature of a receptor tyrosine kinase activation. Insulin receptor is a RTK only, receptor tyrosine kinase only, where RAS MAP kinase activation will result in growth promoting effects of insulin. At the same time, the metabolic effects of insulin is actually carried out by this protein kinase B pathway only. Clear? But final point, I told you a lot of growth factors, GF, all these things including insulin is going to act through this receptor tyrosine kinase only. But one growth factor is a very, very important exception that doesn't act through RTK. You have to remember it is TGF beta. That's called a transforming growth factor beta. Because this growth factor is going to act through receptor serine threonine kinase, not through your receptor tyrosine kinase, RTK or NRTK. It's going to act through receptor serine threonine kinase. Exception, as which ends with the growth factor, very important exception that you have to know for the exam. TGF beta is RSTK, not RTK. Clear? I'll write the final summary at the end, but very, very important to understand. A lot of points is there to understand this particular pathway. So with this, we can move on to the next pathway, that is the non-receptor tyrosine kinases, NRTK pathway. So what will happen in the NRTK pathway? So you can see this is a classic NRTK pathway, non-receptor tyrosine kinases, which is otherwise referred to as JAK-STAT pathway. So you saw in the previous diagram where the tyrosine kinase activity is present on the receptor itself, isn't it? The tyrosine kinase activity was present in the receptor. It's intrinsic tyrosine kinase activity that caused autophosphorylation. Here also autophosphorylation will happen, but the tyrosine kinase activity is present with an external protein that is attached with the receptor, not intrinsic tyrosine kinase activity. This is having some extrinsic, which means some other protein is having this tyrosine kinase activity that is attached to this receptor. That's what we call the JAK protein, right? Fine, very important. So usually, and other principles are all the same, absolutely the same, but the pathways, downstream signaling pathways are different with JAK proteins, but other association principles, everything is the same. For example, once a ligand is bound to this receptor will dimerize, like how you saw in the receptor tyrosine kinases. So they are going to dimerize. Once they dimerize, they will result in phosphorylation of this JAK, that's self-phosphorylation of this JAK proteins, which will transfer the these phosphate groups, phosphorylated phosphate groups, to a new protein called a STAT protein. Clear? Here the STAT is the one that's going to act as a substrate here. STATs are the ones that are phosphorylated. That's why this is called a JAK and STAT pathway. And once these STATs are phosphorylated, they are going to go and bind to the STAT domains. There are a lot of types of STAT are there. Don't think only one type of STAT. STAT 1, 2, 3, 4 like that. Many different types of STAT proteins are there which performs different functions inside the cell. So they go and activate certain domains, certain stat responding regions in the DNA and the gene, so that they can either increase or decrease the transcription, and which means they can either increase or decrease the genetic expression of certain proteins which are necessary for that particular compound. Clear? So why is called a jack? Because you can see both, you have two heads of jack attached to this two types of, two receptors which later dimerize. Clear? So this actually came from a Roman god called Janus. Janus is actually a Roman god who had two heads. Like in India we call Lord Brahma, isn't it, who has three heads. Like that, this Roman god, in Roman mythology, they have a god called Janus who had two heads side by side. Since this receptor also has, once they dimerize, you can see they are like two heads attached on side by side. This Janus, jack receptor, protein. So they look like this Roman god Janus. That's why they named it as Janus kinases. So now you can understand why Janus kinase has been named. But anyway, so let us move on. So what are the types of ligands? What are things that bind to this jack receptors, or this non-receptor tyrosine kinases? Remember, one important point is non-receptor tyrosine kinases, even though you call it as non-receptor tyrosine kinases, they are actually having tyrosine kinase activity, but the receptor intrinsically don't have tyrosine kinase activity. That's why it's called non-receptor tyrosine kinase activity. Clear? But still they are having tyrosine kinase activity on their own. Clear? Not on their own, by virtue of Janus kinases. Still they have tyrosine kinase activity. These receptors do have tyrosine kinase activity. That's what you have to understand. Fine. These are the ligands for this JAK-STAT pathway or this non-receptor tyrosine kinase. I give a simple mnemonic, that is TINS, TERS and GM-CSF and GH. So you can remember as 2 T's and 2 G's. 2 G's are the growth hormone and GM-CSF, and 2 T's are the TINS and the TERS. What are the TINS? Guess. Prolactin. Clear? Some example of a TIN. Erythropoietin, thrombopoietin. So these are the TINs. Then you have certain TERs that can work through the JAK-STAT principle, like interleukins, interferons. So all these things are going to act through JAK-STAT pathway only. Now you can clearly see TINs, TERs, GM-CSF and growth hormone. So these are the classic ligands for JAK-STAT pathway, that is non-receptor tyrosine kinase. You can very clearly see these are nothing but the cytokines, isn't it? That's why I told you these are cytokine based pathway. So if you have any disruption of this pathway, you can disrupt the cytokine stimulation and response, right? So that is why excessive cytokines or some problem with the cytokines is the reason for what you get in autoimmune disorders. So that's why this interference with the JAK-STAT pathway may be helpful in treating autoimmune disorders. That's why you can block the JAK, and these drugs are called as JAK inhibitors. These drugs are called as JAK inhibitors, and you can treat a variety of autoimmune disorders by inhibiting these JAKs, because all the cytokines are going to act through JAKs only, this Janus kinase pathway only. Okay, what are the types of JAK receptors you have? Janus kinases. One is JAK1, JAK2, JAK3. Very important. Clear? A separate type of non-receptor tyrosine kinase is there. I'm not going to talk about that. These are three important types of JAK. So in this, all the three types of JAK, that is JAK1, JAK2, JAK3, can be inhibited by a compound called tofacitinib. Tofacitinib is a very important JAK inhibitor that is approved in rheumatoid arthritis. Maybe they are telling nowadays you can use it in psoriasis also. You can use in certain patients with Sjogren's syndrome, but not yet approved. But rheumatoid arthritis is definitely approved. And alopecia areata, so many conditions is coming up. So tofacitinib, autoimmune disorders again. And JAK1 and 2 can be inhibited, exception of JAK3. JAK1 and 2 can be inhibited by drugs like ruxolitinib. Clear? You can have ruxolitinib, or you can use baricitinib, and you have a compound called lestortinib. Isn't it? So in that, ruxolitinib and lestortinib are usually approved for myeloproliferative neoplasms or myeloproliferative disorders like polycythemia vera. Then you can use it for primary myelofibrosis. In those conditions, especially ruxolitinib and lestrade has been approved for use. Indications we have seen already in the hematology section. I am not going to repeat it. Baricitinib again is approved for even rheumatoid arthritis also. That's baricitinib. Clear? So these are some of the important JAK inhibitors. JAK inhibitors you have to know, but especially this tofacitinib, please don't forget in exam. Very, very important question and very, very important compound also to remember. Rheumatoid arthritis. We will discuss in rheumatology from now on. So we are not going to discuss anything more about this JAK inhibitors from now on. Clear? So these are the importance of this JAK-STAT pathway and JAK pathway, this non-receptor tyrosine kinase pathway. There is nothing about this receptor tyrosine kinase pathway, nothing to tell much about it. So receptor tyrosine kinase, one of the most important ligand for it is the TGF-beta, and you can have this BMP, bone morphogenic protein. Even bone morphogenic protein receptor, if they ask what is the type of receptor, that is called as this receptor serine threonine kinase pathway only, receptor only. So once this receptor is activated by its ligand, they are going to activate downstream substrates, that's called SMAD proteins. These are like STAT proteins that you saw. The SMAD will dimerize and they will further cause genetic manipulation. They are going to bind to certain segments in the DNA. These are SMAD responding elements or SMAD responsive areas where they bind to that SMAD domains and they can either upregulate or downregulate certain genes. Clear? The best example where SMAD regulation is important is in the area where you have something called a hepcidin synthesis. We have studied already. I am not going to discuss in detail, just an overview where this SMAD pathway is important. We have hepcidin regulation. We discussed already. You have a protein receptor called a HFE gene product, isn't it? HFE gene product. Once this HFE gene product is activated by iron, usually the thing that activates is the iron. But in detail, if you want to know, go to the hematology section and see the regulation of iron. So this is the HFE gene product coming from the HFE gene. Once it's activated by excessive iron in the circulating in the serum, this HFE will activate as a cascade and HJV will be activated as hemojuvelin. This hemojuvelin will further activate another protein called BMP, and this BMP will activate the BMP receptor. Once BMP receptor is activated, that will activate SMAD proteins. This SMAD, once it's activated, they go to the nucleus and they go to SMAD binding domains in the nucleus. These are, let us assume these are SMAD binding domains. Once the SMAD binds with certain areas, they increase the transcription of a very, very important gene called HAMP gene. This HAMP gene will be there, that will be stimulated by this SMAD, binding with SMAD. So this, what is this HAMP gene coding for? HAMP gene is going to code for hepcidin, right? So hepcidin will increase. Hepcidin, I told you, it's going to inhibit iron absorption from the GIT, as well as it's going to inhibit the iron release from the reticuloendothelial system. Clear? Which means they reduce the serum iron, which means it's a very important negative feedback mechanism. You can see very clearly it's a very, very important negative feedback mechanism that is happening. So in response to excessive serum iron, you are actually finally reducing the serum iron. Obviously there is a negative feedback mechanism. That's why hepcidin is often considered as a hormone only. Clear? So this is iron regulation pathway. So this BMP receptor, this bone morphogenic protein receptor, is actually a receptor serine threonine kinase, which is going to act through SMAD mechanism. Clear? SMAD is the substrate protein here. So you have seen a lot of stuff, isn't it? So for the last few minutes, so let us put in summary, because even if you understand all these things, when you go to the exams or when you start revising, you might not be able to remember all these things. So let us put as a summary of what all we have learnt. So summary, let us put receptors, put table so that you will understand better. These are the receptors and some of the important ligands for the receptors. and what are the substrates, and what are the second messengers, if any, and what are the terminal proteins that are activated. Terminal proteins that are activated. Fine. First is the intracellular receptors. We have seen intracellular receptors. The ligands for intracellular receptors, you know, they are steroids, thyroid hormones, and vitamin D. Clear? So these are the intracellular receptors, of which steroid hormones have cytosolic intracellular receptor, whereas thyroid hormones and vitamin D will have nuclear intracellular receptors, directly bind to the nucleus straight away, no cytosolic receptors in between. Substrates, we don't have any substrates for this, or second messengers or terminal proteins. These themselves regulate by themselves. We have seen the mechanism already. Second, we have cell surface receptors. In the cell surface receptors, I told you two are the ones we are going to discuss. One is the G protein coupled receptor. In the G protein coupled receptor, you have GQ type, you have GI type, you have you can write G stimulatory type, and you have GI type in the same order what we have seen. That's why I changed it. So GQ type and GS type and GI type, I told you the ligands already, so I will just put multiple ligands. But most importantly, catecholamines. Catecholamines, dopamine, vasopressin, histamine, lot of these receptors are GQ type 1. Even oxytocin, these are G protein coupled receptor type 1. We will see in the respected section, but right now understand multiple ligands are there for this G protein coupled receptors. And what are the substrates? In GQ, you know the substrate is going to be phospholipase C, where the activity will be increased. In GS, the substrate will be adenylate cyclase, where again the activity will be increased. In GI type, the substrate will be adenylate cyclase, where the activity will be decreased. Clear? Which means in S and I, substrate is adenylate cyclase, whereas in Q, it is phospholipase C. Clear? So what are the second messengers? Second messengers in this GQ pathway are inositol triphosphate and diacylglycerol. Second messengers in GS and GI is cyclic AMP, because they are adenine cyclase related. Obviously, here inositol triphosphate and diacylglycerol will be increased, activated by this particular principle. Here cyclic AMP will be increased, here cyclic AMP will be decreased because it's inhibitory. What are the terminal proteins that are activated? You know, in GQ type IP3DAG, the terminal protein that is going to be activated is the protein kinase C. Clear? You can remember by phospholipase C, protein kinase C. That's the mnemonic. And here protein kinase A will be activated. Here the activity of protein kinase A will be reduced. Clear? So these are the terminal proteins. Fine, based on that only, because all these things will have effect on calcium finally. Majority of the, especially the catecholamines, all these terminal proteins, even though they have a lot of other effects, they will have final effect on the calcium usually. That's why calcium is also referred to as a third messenger often. But some books give this, some books don't give that, but it's up to you. Then the next type of receptor is the enzyme link receptor. Among the enzyme link, the first enzyme link receptor we saw is the receptor tyrosine kinases. Receptor tyrosine kinases, remember growth factors, that's all, plus insulin. And one exception that you have to know, that's also very important here, that's a TGF-beta, even though it's a growth factor that acts through the RSTK, not through the receptor tyrosine kinase. So what about the substrates? Substrates for this growth factor, RTK, related RTKs will be like SOS, GRB2, examples I'm telling you. Then you have a lot of other proteins that act through this SHC, we saw that, isn't it? So all these proteins are going to act as substrates. And for insulin, it's the IRS. This is what your exam question will be. For insulin, it's the IRS. That's called the insulin receptor substrate. Fine. What are the effects? Effects, two pathways are there. One is the RAS MAP kinase pathway. These are the proteins that are activated, isn't it? These are the second messengers. These are the ones that are going to act as second messengers. This is RAS and MAP kinase. Similarly, you have PI3K and AKT. And this protein kinase B, this is especially important for insulin. We saw that already. this RAS and MAP kinase and PI3K-AKT pathway for universally for anything that works through this particular pathway, that is receptor tyrosine kinases. So what are the terminal proteins that are activated? I told you a lot of terminal proteins activated like CFOS, CJUN, then CMYC, ELK1, clear, ETC. So many proteins are activated, clear. So FOS, GEN, MYC, all these things are very important. These are terminal proteins, these are transcription factors that are activated by this pathway, clear. Then you have non-receptor tyrosine kinases. The non-receptor tyrosine kinases, the most important are the characteristic TINS, TERS, growth hormone and GMCSF. We know what are TINS, TERS, GMCSF and growth hormone. These are the ligands for activating ligands for this particular type of receptor. NRTK, that's a JAK-STAT pathway. Obviously, in NRTKs you have additional, these are the ones that provide the tyrosine kinase activity for this receptor. It's called a Janus kinase. That's why it's called a JAK pathway or a JAK-STAT pathway. And obviously, the substrate is the STAT protein, and this is the one that will be carried throughout. This is the only protein that is activated in the pathway where they straight away go and activate the nucleus, certain STAT binding domains. And so I'm not going to write any second messenger or a terminal protein because this is the one that's going to act as second messenger and this is the one that's going to act as a terminal protein in this pathway, STAT. Finally, you have receptor serine threonine kinase, that's called a RSTK. In the RSTK, the most important ligand in RSTK, I told you it's the TGF beta. Very, very important. This is what exam questions will be framed upon. Transforming growth factor beta. Then you have BMP. Bone morphogenic protein is a very important ligand. We know that already. Then anti-Mullerian hormone. This I didn't tell you, but AMH is also going to act through this RSTK pathway only. So these are three things that you have to understand, ligands. And you know what are the substrates for this SMAD, and it's going to continue throughout, which means this SMAD is the one that will act as second messenger and SMAD is the one that's going to act as a terminal protein also in this pathway. They bind to the SMAD binding domains in the DNA and they regulate the genetic expression of certain genes and proteins. Clear? So this is in a nutshell. You can see very easily and you can revise this very easily for exams. Whenever you want to go for the exam, just before going to the exam, just revise this once and move on. Very important table that you have to know for exams. I have told you in detail about all these things and I have summarized in detail, and this is the only thing that you have to know, whatever the table I have told you as a summary. Finally, I will complete it with certain mnemonics. They will ask you in exam what are the hormones that use cyclic AMP as a second messenger. Cyclic AMP as second messenger, and what are the hormones that use inositol triphosphate and DAG as a second messenger. The mnemonic for hormones that use cyclic AMP as second messenger is what we refer to as flat champs. This is a mnemonic. I'm not personally fond of mnemonics, but still, just for exam sake, I'm giving these mnemonics. What are F stands for? F stands for FSHA, LH, ACTH, TSH, then C stands for CRH and calcitonin, and H stands for beta HCG, histamine, especially the H2 receptor, very important. H2 acts through the cyclic AMP only. Go through and you will see in the GPCR table also, I have given this. A stands for ADH, V2 receptor only, V1 is different, it acts through GQ. I told you in the GPCR table again. And M stands for MSH, that's called a melanocyte stimulating hormone. Then P stands for PTH, parathyroid hormone. S stands for somatostatin. Suppose if you want to remember one more hormone, you can also remember, that is GHRH, which will not come under the mnemonic, but still this growth hormone releasing hormone will also work through the cyclic AMP pathway only. And the hormones that work through this IP3 pathway, that is GQ pathway, can be remembered by a mnemonic called GOAT-HAG. So where G stands for GnRH, gonadotropin releasing hormone, and O stands for oxytocin, and A stands for ADH, but V1 receptors, I told you V1 acts through this GQ pathway only, and T stands for TRH, TSH releasing hormone, and H stands for histamine, H1 receptors, but here I told you H2 is through cyclic AMP only, whereas H1 is through histamine, and A stands for angiotensin 2 and G stands for gastrin. So these are the hormones that act through IP3 pathway, that is GQ receptor. Clear? Apart from that, you also have to know other second messengers. There are some other second messengers also. Other second messengers are typically cyclic GMP and nitric oxide. Remember, nitric oxide works through cyclic GMP, but nitric oxide itself can act as a second messenger. That you have to know. Apart from that, what are the things that work with cyclic GMP as a second messenger? So, 3 things you have to know. One is BNP, ANP, and nitric oxide. These are 3 things that work through cyclic GMP, which means you can remember this natriuretic peptides and nitric oxide. Still, if you have any confusion with this, you can remember that these are vasodilators. These are vasodilators. So vasodilators are going to act through cyclic GMP pathway. See, yes, ANP is a vasodilator, BNP is an excellent vasodilator, and nitric oxide is also an excellent vasodilator. Still, you have a confusion, remember, by a mnemonic called BAD, where you can remember this BNP, ANP, and endothelium derived relaxing factor, that is nitric oxide. Endothelium derived relaxing factor, that is nitric oxide. So that's why we told a mnemonic BAD, or traditionally we used to remember by a mnemonic called BAD grams. What do you mean by BAD gram? So BAD acts by cyclic GMP. Clear? So that's the mnemonic. But anyway, in whatever way you remember these 3 vasodilators, BNP, ANP, and nitric oxide. All these 3 things are going to act through cyclic GMP as the second messenger only. Clear? So these are all the summary of the entire initial part of the endocrine system, because in the next section we'll be discussing most of the mechanisms of how a hormone is going to regulate itself, something called a feedback. That's what we're going to discuss in the next video. And at the same time, we can see what are the tests and how can you do certain tests to detect endocrine dysfunction, endocrine problem. So with this, we can conclude this video.